Dr. Adarsh, who is Assistant Professor in Medicine from Government Medical College, Kozhikode. He has done his post-graduation and super specialization in clinical immunology and rheumatology from PGI Chandigarh. And he'll be talking to us about systemic medications beyond steroids.
A very good evening to all. At the outset, I will thank the organizers and Prasanna ma'am for giving me such an opportunity to talk. And I'll be talking on going beyond steroids in non-infectious uveitis. So this is the layout for my presentation. I'll be brief on the need for going beyond steroids in NIU, the treatment options available, how to select an appropriate one, and once the target is achieved, how to taper off the immunosuppressants, and few special considerations like perioperative care and pregnancy during the use of immunosuppressant drugs. So why do we need to go beyond steroids in non-infectious uveitis? The answer is eye is an immune privileged site. So it will try to ward off any immune cells with so many other mechanisms. So if there is any fire, any inflammatory fire, you have to douse it. If the fire is too much, then you may have to use something beyond or something bigger than the CO2 cylinders we use. We may have to go for the fire hydrant. So, and when you look at the etiology of non-infectious uveitis, you can find a systemic illness behind many of the non-infectious uveitis cases. And each flare, each inflammatory flare adds more to the cumulative damage to the eye. So prevention of each flare is very important to prevent cumulative damage to the eye. And we know there are, although steroids are wonder drugs, they have significant systemic and local adverse effects, and we have to reduce these side effects of corticosteroids. And already many trials like FAST or visual trials or psychomotor trials have shown that when we add immunosuppressants to steroids, there is good efficacy in achieving remission to prevention of flares and complications associated with it. So we need to look for adding immunosuppressants to steroids. So when should we add an additional immunosuppressant to steroids? When you have persistent inflammation or when you have a severe inflammation that impairs the visual function, when you have a bilateral disease, vitreous haze, when you have posterior segment involvement, when you have macular or optic nerve disease, significant retinal vascular inflammation. And there are conditions when you can't use steroids to higher doses, like when you have an uncontrolled diabetes or when an uncontrolled hypertension, and you have other complications of steroid setting in, you may have to add immunosuppressions. So this is the recent French recommendations for management of non-infectious uveitis. So they recommend that when you have a short-term visual threat, as in a severe Behçet disease, or when you have severe retinal vasculitis, you go for upfront anti-TNF inhibitors. So there are conditions when you have a corticoresistance, you have to use more steroids, more than 0.5 mg per kg to achieve remission. Then you have to go for add an immunosuppression drug. Or when you have corticosteroid dependency, as in when you require more than 7.5 milligrams per day of steroid to maintain a remission, then you have to add immunosuppressive drugs to it. Also, this is the inclusion criteria from the FAST trial. They have used upfront steroid sparing agents when in conditions like Behçet disease with a significant posterior segment involvement, or when you have a severe VKH or sympathetic ophthalmia. We can also use this criteria in our clinical practice on adding steroid sparing agents. So how do we target? We can target B cell directly with rituximab, or we can direct T cells, the immune cells, or we can direct the cytokines like TNF alpha predominantly, or we can even target IL-6 and IL-1 in considering the immunosuppressive drug. So conventional synthetic disease modifying agents are the cornerstone, and they are the time tested and trusted molecules for steroid sparing agents. They are antimetabolites, so that include methotrexate, mycophenolate mofetil, and azathioprine. There are calcineurin inhibitors like cyclosporin and tacrolimus. Also, alkylating agents like cyclophosphamide. And methotrexate is the most preferred one, most trusted one, and have long follow-up also. So you can start from 10 to 15 milligram per week. You can go up to 25 milligram per week, the maximum. And almost all the conventional synthetic disease modifying agents needs a pre-workup, which includes a CBC, an RFT, LFT, and screening for hepatitis B and hepatitis C, and a chest X-ray. And once we achieve a stable immunosuppressive dose, the monitoring is maybe required only 3 monthly or 3 to 4 monthly with CBC, creatinine, and an SGPT. But when you add a new drug or when you hike an immunosuppressant, you may have to do an CBC, SGPT, and creatinine 1 month, 4 weeks later. So this needs to be considered. The preferred biological drug for uveitis is TNF inhibitors. We have infliximab, adalimumab, golimumab, and certolizumab. The adalimumab is the FDA approved drug, and there are enough meta-analysis. There are no head-on trials, but there are enough meta-analysis that says adalimumab is better than the rest of the TNF inhibitors. So we have to give a loading dose of 80 milligram subcutaneously, followed by 40 milligram every 2 weekly. You don't have to admit the patient, you can give it in an OPD basis. The pre-workup is almost same as that of the conventional synthetic dermats. The only thing is that you have to screen for latent TB with a MAN2 or an interferon gamma release assay. And the monitoring is not as stringent as in the conventional synthetic dermats, and you can you can have a 3 to 6 monthly, but preferably 3 monthly follow up with the CBC and an SGPT and a creatinine and albumin. There are few non-TNFI biological drugs available like IL-6 antagonist tocilizumab targeting CD20 like rituximab, and there are only case series or case reports. We don't have any clear-cut evidence on their effectiveness. And the new molecule is Janus kinase inhibitor, which is tofacitinib. The thing is that it is not a biological drug. It is 1/10 cheaper than the biological drug, and they are as good as biologicals in many of the rheumatological conditions like spondyloarthritis or psoriatic arthritis. So there are enough case reports and case series coming up with the use of tofacitinib in many of the uveitis syndromes. Intravitreal immunosuppression with adalimumab, methotrexate, and sirolimus. There are trials and they have shown to be effective. The problem is you need to have expertise, and also you have the risk of flares are more with the intravitreal injections when compared to the systemic immunosuppressant drugs. So how to select an appropriate option? The thing is that it is based on disease characteristics. If the systemic disease, like if the systemic disease is an spondyloarthritis, or if the systemic disease is sarcoidosis, it depends on the systemic disease and the extent of involvement in non-ocular involvement in the disease. And you have the severity of the inflammation, how bad is the visual acuity which is affected, and patient characteristics like presence of chronic kidney disease, diabetes mellitus, liver disease, and the cost of the drug, insurance, availability. These are all need to be considered while selecting an appropriate option. The first line is always anti-metabolite. Methotrexate, mycophenolate mofetil, or azathioprine, they are equally effective, or a calcineurin antagonist like cyclosporin or tacrolimus. The French guidelines 2023 says that the primary treatment for chronic or recurrent idiopathic or HLA-B27 related uveitis without a rheumatological manifestations is methotrexate in adults. And in the FAST trial subgroup analysis, they have shown that in posterior uveitis and pan uveitis, methotrexate work better than MMF. And few conditions like severe uveitis in Behçet or in JIA, you may have to use TNF inhibitor, that is adalimumab, upfront. Two molecules, etanercept, which is a TNF receptor antagonist, and secukinumab, which is an IL-17 antagonist. These are not recommended to be used in uveitis, and they have shown to have some deleterious effects in eye. If the first line fails, look for non-adherence infections and muscular syndromes like lymphomas. And if there is a vision threatening, hike the steroids. You can even use pulse glucocorticoids. And you can switch the conventional synthetic dermat, methotrexate to mycophenolate mofetil or calcineurin inhibitor. You can add on a drug. You can you can combine an antimetabolite with a calcineurin inhibitor. You can combine a TNF inhibitor with an antimetabolite. And even short term, in Behçet disease, even a short term treatment with infliximab, 2 or 3 infusions along with azathioprine and maintain with azathioprine is shown to have a good able to help in achieving remissions, especially when you don't have enough finances to continue with the TNF infusion. So this can also be tried in our clinical practice. The problem with immunosuppression is adverse effects. Most common is infections, and for TNFI, demyelinating disease and heart failure needs to be considered. and for calcineurin inhibitors and anti-metabolites and bone marrow suppression. These are the things we regularly monitor, so we can pick up the adverse events very early. When to taper, the target is to achieve prednisolone less than 7.5 milligram in sustained control. And when the remission is achieved for at least 2 years, we can consider starting tapering of the steroids or immunosuppressions. First, you taper off the steroids and then you taper off the immunosuppressive drug. It should be done slowly. And maybe if you are on 5 milligram prednisolone OD, you can taper it to 2.5 alternate day for 1 month, and then 2.5 OD for 1 month, and alternate day 2.5 for next 1 month, and then taper off and stop. And maybe 2.5 or 5 milligram per week reduction of methotrexate should be sufficient enough. And monitor closely for any relapse in the uveitis. Few trials in pipeline. The most important is advice, this adalimumab against methotrexate bar MMF. So looking hopeful for that. Few specific scenarios. The one is vaccination. You have to avoid live attenuated vaccination. You have to give influenza and pneumococcal immunization to all, preferably before at least 2 weeks prior to starting of the immunosuppressive drugs. The one important thing is perioperative care, whether it is an ocular surgery or the systemic surgery. The disease should be in quiescent state, and you have to weigh the stopping immunosuppressions against the chance of flare. If you have a retinal vasculitis and the chance of flare, one flare itself can have very difficult times ahead, so you may have to continue with the immunosuppression and go ahead with the surgery. Conventional synthetic disease modifying agents should be continued perioperatively, and for biologicals you have to stop it for one dosing interval. For infliximab, for adalimumab it is 2 weeks, so you stop it for 2 weeks and do the surgery, and once there is a good wound healing, you just continue with the adalimumab. Pregnancy, drugs that we can use are azathioprine, cyclosporin and sulfasalazine and TNF inhibitors. And if the patient comes with a serious infection, stop all the drugs except glucocorticoids. Glucocorticoids should be continued throughout anything, so it should not be stopped abruptly. If the patient has hepatitis B or hepatitis C, you treat the hepatitis B and C and you can start the immunosuppressive therapy. The patient has active tuberculosis, treat the tuberculosis with ATT, and at least 3 months of treatment you can consider giving immunosuppressive therapy for them. And if the patient has latent TB with the MAN2 positivity or IGRA positivity, you have to treat it with LTBA treatment. At least 1 month into the therapy, you can start immunosuppressant drugs. So the take home points is there is a multidisciplinary approach is needed, because there can be a systemic cause for the non-infectious uveitis, and the drugs and the adverse effects may need a multidisciplinary approach. A precise description of non-infectious uveitis using some criteria is very helpful, because most of the non-ophthalmologists will be less aware of the investigations in they won't be able to read the investigations in ophthalmology. So if a clear, they will be treating what the ophthalmologist says. Then chronic granulomatous anterior uveitis, they will just treat the chronic anterior granulomatous anterior uveitis, and they will be looking only for the things that are associated with that. They will not be cross checking anything that. So if we get an diagnosis of, okay, this is pan uveitis and these are the things, then it will be very easy for us to look for what may be the best immunosuppressant treatment that we can offer. So consider steroid sparing agents in non-infectious uveitis. First diagnosis or all follow-ups, so that we can at least avoid some of the FACOs or some of the MIGS with this better inflammation control and better steroid sparing activity. Methotrexate seems to be the best initial option in most non-infectious uveitis, and adalimumab is the initial choice of the biological drug in NIU. Monitor treatment response, but look for drug adverse effects too. Thank you.
Thank you, Dr. Adarsh. It was a very wonderful talk, because most of the facts are known more to the medicine people than us ophthalmologists. Thank you, Dr.